Hello, I'm Jodi. I'm Charlotte's co-worker. I'm a speech and language therapist, also based at Queen Square. And again, I'd like to thank the International Alliance for giving us both the opportunity to share our work, which we're particularly excited about because we've only been working together for a year or so. So I'm going to kind of dig a bit deeper with some of the data that Charlotte and I have collected and talk about the assessment and the management of cough for airway clearance in our complex patient group. And when we first wrote this presentation and submitted the abstract, we actually called it multidisciplinary because, hey, there was a speech therapist and a physiotherapist standing in the same room. Surely that made it multidisciplinary. But we quickly found out that actually this wasn't multidisciplinary, this was heavily interdisciplinary because we weren't working in parallel. We were having to rely on each other's skill base and knowledge and management to try and manage these patients. So everything we did built on each other's knowledge. And I can say for the first time probably since I've been working in the last 12 or 13 years, this is the first true interdisciplinary clinic that I've ever managed to be part of. So again, there's no disclosures from my part, but we'd like to thank the MDNA North London for funding our conference attendance. So I'm just going to do a very quick recap of the things that we've heard about already in this session. Is in that in motor neuron disease, ineffective cough is common, and that results from inspiratory and expiratory muscle weakness plus or minus bulbar impairment. And then it's this reduced ability to cough that leads to accumulation of secretions, and it progresses the respiratory morbidity and mortality. And there's a few authors that are writing about this. Michelle Chatwin is a big author, and Tina Anderson has started to do some work in this area in relation to bulbar issues in airway clearance and MND. So the sorts of things that we've heard about already are breath stacking, manually assisted cough, and mechanical insufflation, exsufflation, so cough assist devices. And we're guided very strongly by the NICE guidelines that were written 2 years ago about us offering cough augmentation to people with MND who can't cough effectively. And wouldn't it be nice if it was that simple? So we know that we get respiratory dysfunction, and we know that we get bulbar dysfunction in MND. We know that bulbar dysfunction can cause problems with the voice and the glottis can't close. So if you can't take a good breath in, you can't close the glottis, and you can't then expel using your expiratory muscles, you can't cough. So it's very simple. You help people to cough. You give them some cough augmentation. But it's not that simple, and it never is that simple in our patient cohort, because we know that if there's a patient of ours that has bulbar dysfunction, they're going to be more likely to have an oropharyngeal dysphagia, so problems with their swallowing. And issues with swallowing in MND are pretty well understood. And it's not uncommon for our patients with bulbar difficulties to have a collection of food, drink, saliva in the mouth, in the throat, and or the upper airway if it becomes aspirated. And if you apply a cough augmentation, such as a cough assist, which blows air in and then out, you're putting the patient potentially at risk of increasing symptoms because you're blowing that material into the airway. And cough augmentation via perhaps a cough assist is maybe not the best route at that particular time until you've sorted out all the other additional issues. And if the patient doesn't have dysphagia, perhaps we can set them up more easily on a cough augmentation, but the bulbar issues might still manifest when you add positive pressure to the upper airway. So as soon as you put positive pressure through, if you've got weakness or spasticity in the upper airway, you can get collapse like Charlotte was talking about. So it makes cough augmentation more difficult, and it makes breath stacking more difficult because you can't close the glottis as well. And on top of this, if we take a step back and look at the wider picture, our patient might have cognitive and behavioural changes. There may be pseudobulbar effect. There may be neck weakness and altered posturing. There may be upper limb dysfunction, so they can't use these devices independently. And loss of mobility puts these patients at more risk regardless. So it's pretty tricky, and the problem solving that has to go on behind that is pretty complex. Why do we know that bulbar impairment makes things more complex? Well, we know it's been written about. It's been written about in the last couple of years, but also our patients on the unit or in our clinics tell us. They say, that cough thingy that sits in the corner of my room, it makes me cough more than I did to start with. I put it on and I can't breathe when I use it. That's pretty alarming. And I've just stopped using it. I don't find it beneficial, and actually it makes things feel worse for me. So we know that some of our patients aren't tolerating what we give them. And we're faced every day with these clinical challenges, one of which is, of course, our patients advocating for themselves. They hear about a cough assist machine. They want to know more about it. They've heard that, people they know have used one and it's beneficial. Perhaps another professional have told them about these cough assist machines. We're lucky, like Charlotte said at Queen Square, that we do have cough assists that are available. And if they're available, are we more likely to give them out? But we need to be careful about who we're giving them to. They're not necessarily cheap pieces of equipment. And not only would they carry a financial burden, but they carry a kind of psychological burden. If you're giving out equipment that a patient can't really use and they're struggling to know how to get to grips with it. There's not huge amounts of research in MND about the benefits and burdens of cough assist. And of course, the bulbar issues continue to be a big challenge for us. And it's the bulbar issues that we try to address before we set up any cough augmentation. And that's the kind of tack we've taken, because if you look again back at the guidelines in 2016, it reminds us as clinicians to look at reversible causes and treatable issues before you provide kind of long-term treatment options. So we do tend to look at secretion issues, dysphagia, before we go as far as offering out cough augmentation, just to check that there's no issues there. And by exploring the bulbar system in a bit more detail before we give out cough augmentation, it really helps us to understand why the cough is weak. Is it really the bulbar issue? Is it the glottis? Or is it all respiratory? Or likely is it a combination of both, and to what extent is it both? It helps us define the etiology of the phlegm and the secretion issues. Not all of our patients have lots of watery, loose saliva. Some of it is actually quite sticky phlegm and actually looks a bit more reflux related. So if we know what the secretion issues are, we can tailor the treatment. It might be that they need some PPI or some gastro management to reduce some of the phlegm and stickiness. And then it really helps us, or we've learned over the last kind of 8 or 9 months, that it's really helping us to define our selection of cough augmentation and tailor its management to the individual. So we've come up with a kind of joint assessment protocol, and we're just going to give you the very broad headings that we look at. And Charlotte and I will either deliver this together or we'll do it as individuals and regroup at the end of the session. And these are the kind of main headings that we look at before we offer cough augmentation. So, of course, like most clinicians, we would take a clinical respiratory history, so history of chest infections, hospital admissions, symptom reports of phlegm, secretions. We would take measures of their inspiratory and expiratory muscle function. And then we would look clinically at any signs of bulbar weakness or spasticity by listening to their speech and doing an oromotor assessment. We would look for signs and symptoms of dysphagia, and maybe a local speech therapist is already involved with this patient. We would look for secretions, whether they look salivary or something more thick and mucousy. Helpfully, we can look a little bit closely if someone is dysphagic in our clinic and they have a reflexive cough when they are, food and drink are being aspirated, we can get a sense of whether the reflexive cough actually is a bit better preserved than the volitional cough early on in the disease. Look at any cognitive and behavioural changes that might be a barrier to setting up cough augmentation. Pseudobulbar effect, we've certainly had at least one patient in our clinic who's been so affected with their pseudobulbar presentation that we couldn't set anything up because of that laughter, emotional laughter. And then we look at their mobility and how well they're able to mobilise to clear their lungs naturally. So again, same data set as Charlotte, 52, but we're taking a slightly different angle on it this time. So as Charlotte said, 71.5% of these patients, so 37 of these 52 patients had a peak flow under 270, and they would have historically been referred just to physiotherapy, but they got a joint or kind of combined assessment. And here's an example of the sorts of patients that were coming through, just for those who don't work in this area can kind of get an eye on it. So a 58-year-old lady with ALS, she uses a wheelchair routinely, and she had a moderate speech difficulty, and she'd had one recent chest infection that was treated by the GP at home, and she was referred into our clinic with symptoms of weak coughing and difficulties clearing her secretions. So we measured her peak flow, which was 200, so low, but not the lowest we've seen. She clearly at that point presented with an unmanaged dysphagia, so she had swallowing problems. And if we're able to play the video at all, I can show you the video fluoroscopy here, if it will play. She had an unmanaged dysphagia, so you can, if this is a video fluoroscopy, so swallow X-ray, and the black kind of spots there in the throat are the barium or the food and drink, I'm not sure it's going to play, which are collecting in the throat and also entering the airway. And in our assessment, it became really obvious to us that actually this coughing was totally linked with eating and drinking. And
transport the bolus
when they, you might be able to turn the sound down, they are coughing because they are aspirating. And we found that perceptually the reflexive cough was a little bit stronger than the voluntary cough, but there wasn't always a cough response elicited. So we could explain why they were getting chest infections. It wasn't just because they had a weak cough. They had a much wider bulbar issue. So before we set this person up on cough augmentation, we referred them back into their local speech and language therapist, who then made referrals for a gastrostomy and got on top of the dysphagia management a little better, and they came back to clinic 4 to 6 weeks later for us to look at it again. A second example might be a 72-year-old chap with bulbar onset motor neuron disease. He's mobile with a stick and has a more severe speech problem. Again, he was referred to us because he's got a weak cough and difficulties clearing secretions. And we looked at our protocol and found that he actually had a really well-managed dysphagia. He'd chosen to be nil by mouth because swallowing had become too difficult, just had the odd cup of tea a day, and he had a gastrostomy. We identified that he had really very poor thoracic expansion, and he presented to us with a very wet, gurgly voice. He was drooling, and he couldn't generate a really nice, crisp cough. So this chap, and this is an image of his throat in the bottom right-hand corner, and those watery bubbles that you can see are the secretions that we saw when we popped a camera down. So he's got lots of secretions sitting in his throat, and they, I don't know whether that turns on, they are sitting around his airway. So if we put a cough augmentation or pressure into that throat, you would probably see those secretions get pushed down into the airway, and potentially he would become more symptomatic. So in the first instance, he got referred to our MND team to just improve the management of secretions pharmacologically, and then he came back for us to reevaluate his cough again 1 or 2 weeks later. So in terms of outcomes, It was interesting just to pull those 37 patients together and just look at who had primary needs that were Bulba and versus not so. So 10 out of those 37 patients, so 27%, had primary needs associated with an unmanaged dysphagia and or secretion management issues. So looked a little bit like those two patients that I've just shown you to a greater or lesser extent. Despite that, we still were actually able to set up 2 of those patients on cough augmentation. And that might be because one patient has chosen that he didn't want a gastrostomy, so we had to find a way to help him best. We trialled a cough assist, and we were able to work around the dysphagia, but we just had to work a bit harder to make sure that that was working for him. On top of that 27%, 8 of those patients, so 21.6%, had issues with bulbar collapse or stridor. So they didn't necessarily have an unmanaged dysphagia or secretions, but when we put pressure in their throat to augment their cough, the bulbar muscles collapsed. So it felt like the patient, to them, weren't able to breathe, or they were getting noisy, stridorous breathing, or we were provoking dry coughing. So in our cohort, nearly 50% of referrals had bulbar issues, which needed interdisciplinary troubleshooting before we could successfully set them up on cough augmentation. And we looked at what the benefits were then of having a speech therapist in clinic or a nasendoscopy, just to have a little look down and understand the secretions and the dysphagia, and we kind of had generated some of these benefits. We feel that it's helped us identify the cause of the cough weakness a little bit better. It's helped us to define the nature and the cause of the secretions a little bit better. It's helped us to work out what contribution dysphagia makes to the cough and the chest symptoms. Helps us look at the cause of stridor or airway turbulence if there's any pressure added. And it's helped us tweak the pressure settings. So sometimes we pop the scope in with the cough assist on to see whether we can change the pressures to minimize any stridor or bulbar collapse. So in conclusion, we all know that deterioration in cough and bulbar function are common in motor neuron disease. And the assessment of cough and airway clearance without consideration to the bulbar function, we feel can result in poorly tailored management programs. And in our own experience of kind of meeting patients who've been set up on cough assist they don't use, we can certainly say that kind of on the shop floor that certainly does happen. So at this point, these are the recommendations that we would make to the field. The interdisciplinary assessment in an ideal world by a trained speech and language therapist and a physiotherapist is helpful to ensure that all the bulbar issues are assessed and managed prior to setting up cough augmentation techniques. And that joint assessments upon initiation of cough assist or cough augmentation does help to optimize pressures and the tolerance of cough augmentation in those with bulbar dysfunction, leading hopefully to safer and more clinically effective cough augmentation and airway clearance. Thank you for listening, and happy to take any questions.
Other questions? Yes, there are questions.
Hello, Jane Lester from Manchester Care Centre. I wanted to ask a question to all 3 of you in a way, whether some of the interventions, the very early interventions that Diane described in your multidisciplinary clinic, has any impact on delaying some of the later interventions, such as the need for NIV, or with the very early interventions, the need for cough assist? So whether you can delay that need.
Oh, so is the question around if we set up cough augmentation earlier, it delays the need for NIV?
Yeah.
Is that right?
Or setting up some of the early interventions, so with the breath stacking,
Yeah.
whether that might delay the need for cough assist as well.
Ah,
So
okay.
both elements.
Yeah, I mean, I'll open that up to these guys as well, but at the moment, I don't think we've worked long enough in this field to see whether that actually has an impact, but most of our referrals come from our respiratory physician, so a lot of our patients get set up maybe on NIV and cough augmentation at a similar time, perhaps because the respiratory failure is, impacting both aspects. But I don't think, Charlotte, correct me if I'm wrong, we're seeing at the moment anybody who's set up on cough augmentation earlier, it would necessarily delay the need for NIV because they both work differently for different reasons.
Yeah, probably thinking more of sort of the early breath stacking with the very early people who are actually asymptomatic at that time.
Yeah.
So, Diane.
Yeah.
Right, I don't think we can actually hear what you're saying. And this is going to be the last response, and then we have to move on.
I don't think that it would necessarily delay the need for a cough assist device. I do think that setting people up early with a chest management plan means that when the time comes that they need a more, as we would say, invasive device such as a cough assist, they already have incorporated a chest secretion clearance technique into their daily routine, and actually introducing a cough assist is not so much of a big thing. I think the problem we currently have is, because the research is still evolving, is that at the moment we tend to give everything at the same time, an NIV machine and a cough assist, and sometimes we found that is too much for our patients. So actually, if we start earlier with the cough augmentation, it might help them in their journey in terms of when they're given things.
Okay, thank you very much.
Thank you.